My name is John Baptist Bwanika. I'm the Senior Surveillance Monitoring and Evaluations Advisor on this USAID's Malaria Action Program for districts. In order for us to deliver this program, we had 3 cross-cutting areas, including surveillance, monitoring and evaluation, SBC or social behavior change, and gender and youth. In this poster, I'm here to present to you some key highlights and lessons learned from the implementation of the 3 cross-cutting areas. Starting with social behavior change. Under social behavior change, our main interventions were centered around enhancing positive behavior among the people that we serve or the beneficiaries. We encouraged them to use early lines appropriately, early testing and treatment seeking for malaria, and prevention of malaria in pregnancy, and then adhering to the malaria test results. The SBC approaches were centered around the community, then from the community to the household, and then from the household down to the individual. At the community level, we had interventions centered around encouraging positive deviance, and we used channels such as community dialogues, and then key influencers coupled with the use of religious leaders to ensure that the community takes on positive behavior towards malaria prevention and case management. Then around the household, we encouraged risk perception, a high risk perception for malaria in the household to ensure that the households are aware that they can catch malaria at any particular time, and therefore encouraging malaria prevention approaches. And then around the individual, we try to make the individuals understand the cost of malaria towards the incomes of an individual, and therefore encouraging positive practices around the individuals. For example, some of the successes that were registered under social behavior change and communication were the key influencer program that was coupled with the zooming in approach. In the zooming in approach, we worked with health facilities to ensure that we pick information on villages that were bringing in high numbers of malaria cases in the facilities. And then from the health facilities, we picked the villages that had the highest number of positive malaria cases. Then we moved down to those villages and we implemented the community approaches of community dialogues and ensuring preventive practices for malaria. Then for surveillance, monitoring and evaluation, we had a number of approaches. First of all, I need to mention that we worked under the Health Management Information System that is already a system that is in place by the Ministry of Health. So we worked with the Division of Health Information to build the capacity of health workers to properly record and then collect information and have it reported into the national DHIS2, or the electronic version of the Health Management Information System. Our main target was to ensure that we improve reporting, but then also improve the quality of the data that is recorded in the system. After that, we worked with the health workers and the district health management team to ensure that there is data use. Data use of the data collected through the Health Management Information System at all levels, from the national level down to the district level, because this was a district-centered program, and then down to the facility level, making sure that we understand the malaria burden in our districts, understand the malaria burden in the catchment population of the facility, and therefore be able to take action and ensure that we prevent malaria among the beneficiaries. We also worked with a number of people in implementing this program. At the district level, we worked with district technical resource persons, and these were mainly health workers who are more experienced in implementing the malaria program, that actually cascaded their technical expertise down to lower level facilities to ensure that there is proper data recording, data reporting, and then data use. For example, we were able to achieve a number of successes through the surveillance, monitoring, and evaluation cross-cutting area. For example, we encouraged IPTP3 reporting, which is actually data on intermittent preventive treatment for malaria among pregnant women. And this we started at 0%. We improvised to have this reported on the HMIS form because it wasn't originally there. Then it went up, and as we speak right now, it has actually gone up to about 70% of pregnant women receiving IPTP3. And also, over 95% of the health facilities are now able to report IPTP3 into the national DHIS2 system. Of course, there are so many others. We've carried out mentorships using the technical resource persons, as I mentioned. And as I speak right now, a number of health facilities are able to use the data that they collect through a number of approaches. For example, there is one that I need to mention on the malaria normal channels or malaria threshold channels, which are actually now being plotted in the facilities to understand situations or times when malaria is actually going up beyond the expected, and therefore taking action at a community level. The third area was the area on gender and youth. Under gender and youth, the program started by doing research, qualitative research, to understand the dynamics of malaria programming among the youth, and the results were actually shared at all levels. Using the information or the findings from the gender and youth qualitative assessment, we were able to mainstream gender and youth activities across the 3 result areas of the project. This was actually targeted at ensuring that we actually cater for the youth across all levels of intervention. Some of the areas that worked, first of all, we were able to create youth and gender-friendly environment at health facilities. And the aim of this was to improve awareness among the health workers of the needs of the youth at the health facility level. We also worked with health facilities to ensure that we improve services around antenatal care for the adolescents by making sure that we provide friendly services at the health facilities. Then we also worked with the community component, the SBC component, to ensure that we encourage male involvement in the malaria treatment, first of all for their family members, but then also for their individual personal malaria prevention and treatment. Briefly, that's it about the poster, but I'm happy to share more about the findings. Once again, my name is John Baptist Bwanika, Senior Monitoring and Evaluations Advisor for MAPD. Thank you.